I'm Chris Williamson. I'm going to be speaking with Dr Bob Gill again this afternoon. It's a Workers' Party initiative called the Doctor, and we'll be obviously focusing on the National Health Service. And we'll have a discussion with Bob and I in the first instance, where we're going to be focusing on the national health hospitals and how the hospital network has changed over the years, and see how the conversation develops from there. But this isn't just a discussion between Bob and I. This is an opportunity for the wider general public to put their questions and comments to Bob. Bob Gill is a campaigning general practitioner who produced the documentary film, The Great NHS Heist, which is talking about how the National Health Service is being systematically dismantled and sold off, and well worth a watch. Although it's a few years old, it's probably even more relevant today than it was when Bob actually made the documentary a few years ago. But let's kick off with that, though, Bob, if we can. I mean, how has the hospital network changed over the years, and what impact has that been having?
Hi, Chris. Thank you for that introduction. So we've covered in the two X spaces. We've had an overview, and I went into what had happened to primary care last week. But this week, I want to just explain what's happened to our hospitals. The biggest take-home message is that there's been a massive reduction in bed capacity, and what that means is the closure and downgrading of local hospitals. In fact, that was what drove me into becoming an activist on NHS and against privatisation, was the downgrading of my local hospital, Queen Mary's in Sidcup. We lost the inpatient beds, we lost the maternity unit, we lost the A&E unit. Now, many people have suffered similar downgradings and closures, and as a result, when you become seriously unwell, very often there's a long wait in A&E. If they decide you're sick enough to get admitted, there's a long wait for a bed, and often people are supervised, if you can call it that, in corridors. And we know for every person waiting more than 24 hours for a bed, there is 1 in 80 preventable deaths. And this has now been normalized up and down the country. No longer shocks the fact that there aren't enough beds in the hospitals. So that's the first thing, a capacity problem. But we have a huge workforce problem. We can't retain staff, we can't recruit staff, and what many people aren't aware of is what has actually happened to those staff in the hospital. Well, we've seen a transfer of control, a transfer of ownership of what happens in the hospital. The responsibility is left with the clinical doctors and nurse teams, but all the power, all the decision making happens with the administrators and the managers. And this decoupling started to take place back in the 80s under the Griffiths reforms. But what also went along in parallel with that, and I can talk particularly about doctors' training, is there was an erosion of the teamwork, the firm structure within a hospital, and they shortened the length of times of training jobs down from 6 months as a minimum down to 4 months. And also the job security that was there. For example, when I started work in the NHS, I was in the same hospital for a minimum of a year, and then you rotated into other jobs. Given there was a firm structure, given you were in jobs for longer, there was a very good chance you came out of that job quite confident and competent at what you're doing, with a sense of autonomy and a bit of control over what goes on. All those things have gradually diminished or disappeared entirely. So when I admitted a sick patient when I was doing a medical job, very rarely was there a problem of admitting that person to a ward. And I knew, although I was a junior doctor, they would be reviewed by a middle grade doctor and ultimately by a consultant who would make the decision whether to keep them in or to send them home. But because of the lack of capacity, that safety net has been removed, and people are having to make life and death decisions based on bed capacity and not what is safe for the patient. So you don't have to have a strong imagination to see that this is inherently more dangerous. So now, I regularly see patients who are discharged from hospital without adequate planning. They're not necessarily recovered or in a fit state to be home. And the other part of the problem is there's a breakdown in continuity of care. So when I trained in the 90s, if I'm doing a medical job, more often than not, people who we admitted, who recovered, we sent home, we would follow them up in clinic. Well, following up medical patients in clinic now is a rarity. But I put it to you, that is a very essential learning point for the doctors, and it's very reassuring for the patient, who will finally have a chance to ask some questions that they may not have asked, how they've got on with their new medical treatment. So these natural inbuilt systems of good quality for the patient and good training experience for the medical staff have been gradually sucked out of the system. So camaraderie is down, you leave with less experience, and the patients are taking more and more risk is being taken with patient safety. So you have this erosion of medical autonomy, and when things go wrong, there's no accountability because you aren't suddenly going to conjure up 100 extra beds. Those decisions are made out of reach of any influence by the medical staff. And when they do raise a concern, they face a very high risk of, first of all, being ignored and then being pressured to keep silent.
Well, what do you make then of the propaganda, if I can put it like that, from the government, from West Streeting and so on, who are saying that they are fixing in the National Health Service, that they are bringing waiting lists down, that everything's under control, there's nothing to panic about, and that all the problems are the fault of the previous Conservative administration?
Well, as you say, the word you use is accurate. It's propaganda. There is no alteration in policy flow between the last government and the current government. In fact, every government for the last 40 years has continued this trajectory. The rhetoric of blaming the last administration, every politician uses that trick, and hopefully we can see through it. In terms of investment, the investment isn't going in increasing NHS bed capacity. It's about transferring what care they can out into the private sector. That's another way of reducing the waiting list, of course. You can also administratively manipulate the waiting lists by making patients disappear off waiting lists, or to say, well, you didn't respond in time, so you're now cancelled and you have to be re-referred. I come up across this sort of obstruction and hurdle jumping every day within my practice, where people who may not have received a letter are instantly discharged. They're not given another chance to have their appointment. So there are ways to manipulate those waiting lists without providing any service. And the other investment is going into a scheme called Care Closer to Home, which in fact is discharging sick people with very expensive IT systems, and apparently staff within the hospital are somehow going to be able to monitor these people safely. This is a wasteful and dangerous exercise.
I was going to ask you about that, Bob, actually, because I mean, you're a GP in Surrey, I believe. Is that right?
No, in Sidcup in Kent.
Oh, you're in Kent. I do beg your pardon. I thought you were Surrey. I'm so sorry. Well, there was well, Surrey's not that far from you, is it? I suppose. But
No.
there was an article I saw in on the BBC website on where are we today? 7th of November. So a couple of days ago, and it was talking about this rollout of new technology. The headline was NHS app means more home treatment for patients, and it was saying patients of 3 Surrey hospitals will be able to get more treatments in their own homes thanks to a new digital technology. And they named the hospitals, and they're talking of things like blood pressure, oxygen levels, etc. Can be shared in this way. I mean, I mean, it's being portrayed as that's that's a really positive thing. I mean, how do you respond to that, Bob? I mean, is it a good thing, or are there dangers with that? And is it a fig leaf really to conceal some of the problems that you've been identifying?
Well, as well as being a bung to the big tech companies, it's inherently dangerous. We talked last week of the diminution of skilled people within primary care. Well, where is this extra workforce coming from that's going to safely monitor these people being dumped at home? There are many scandals within the NHS whereby government come up with a policy, they don't prove that the policies work. They just announce a proposal. There's no trials, there's no testing, there's no independent testing, certainly. They might do a very small, controlled, fiddled trial and then say, well, it works, here we go. But in the real world, it's not so simple, I'm afraid. If we take a little trip down memory lane, I want to take you, first of all, to the scandal. You may remember the baby P scandal back in the mid 2000s.
Yes, yeah.
Now, if you analyze this without the political bent, this was a case of a child who unfortunately died at the hands of his own parents. But this child was under the care of social services and of a specialist hospital team, supposedly. And this hospital team was attached to a very famous hospital called Great Ormond Street Hospital, a world-renowned hospital.
Yeah.
And what transpired was that the child, on his last visit to the hospital, was seen at this peripheral hospital unit, which had already lost 2 pediatric child safety specialists because of the conditions within there which they were working. They resigned. So 2 out of 4 consultants had resigned. And unfortunately, on the day that baby P was seen, he was seen by a doctor who had no qualifications in child safety. So you have a staffing problem, you have an expertise problem, and you have a downskilling problem. What did the government manage to successfully do? It pinned all the blame onto social services.
Yeah.
In fact, it was Ed Balls at the time who managed to
I remember,
switch everybody's focus to social services. The head of social services was hung out to dry, but the effect of NHS privatisation was totally ignored or missed by everybody.
Yes.
That's just one example. I'll give you another example. The mid-staff scandal. Now, this was a scandal which took place several years later, and it was involving a hospital that was very desperate to become a foundation trust. In order to become a foundation trust, the senior managers' focus, in order for them to get their bonuses, was to be within budget. And to be within budget required them not employing adequate staff. As a result of that, there were many preventable harms and deaths caused. And one particular daughter of a patient who was resorted to drinking water out of a flower pot because there was no basic provision for them on the wards.
Wow.
She developed a campaign, campaigning for staffing numbers. But actually, what it turned out, there was a public inquiry on the back of that. Now, the public inquiry was the Francis inquiry. Now, Chris, with your parliamentary experience, you can dictate the outcome of the inquiry by choosing who's going to lead the inquiry and setting the terms of and conditions, right?
Yeah.
My analysis of that tragedy was the managers wanted to remain within budget in order to secure their own careers and bonuses. And as a result, they cut corners in terms of staffing and patients died. What did what was his conclusion? We need to support whistleblowers, and the nurses were uncaring.
Right.
And that's the perception left with the public.
Yes.
But the reality was the rush to foundation status was a prerequisite step as part of the privatisation of our hospital stock.
Yes, indeed. I mean, I was just going to say, Bob, is that part of the drive and the the demonisation of the NHS staff, the nurses, in that sense? Uh, is it as sinister as that? Is in terms of, was that done, do you think, to to facilitate, to help move the dial more in the direction of the privatisation agenda?
Well, it's pretty helpful. First of all, you need a scapegoat. You need a plausible
Yeah.
scapegoat. It happened to be that these nurses who were run ragged did lose a bit of humanity and compassion, but anybody in those circumstances would. But the main purpose it served at that time was to deflect responsibility from government policy and protect the privatization project at all cost.
Yes, yes, no, indeed. Bob, I mean, you mentioned a few moments ago about you were going to give us a trip down memory lane, and you talked about some historical examples there. And we opened the discussion this evening about the hospital network and how that's changed. Just give us a feel, will you? I mean, I guess the NHS has never been perfect, but give us a flavour, really. For I mean, some of the older listeners will remember, but for younger people listening in, they may not be familiar with what the hospital network used to look like. So, how has it changed, and how why has that been detrimental to patient care?
So we used to have a system of district general hospitals. Then you would have more specialist tertiary centres. And back in the 80s, there still existed hospitals in the community which were just for recuperation and rehabilitation. Most of that land and assets have been sold off. So most of them you couldn't find anymore. You'd have a housing estate built on them. The hospital that I talked about, Queen Mary's, which is my local hospital, half of the land has been turned over to luxury retirement accommodation.
Yeah.
So we've had an asset stripping gone on. Within the hospital, for example, when I was doing chest medicine, when I worked up in Hull, I would be in clinic as a dedicated respiratory physician in training with a consultant, with another similar junior doctor to myself, with other clinics going on. And we would learn from each other. If I wasn't sure of something, I'd run it past the consultant or the registrar. If we found that a patient actually didn't have a respiratory problem, the problem was primarily a heart problem, it would be quite possible to pick up the phone and ring the cardiology clinic going on down the corridor and say, please, could you fit this person in as an extra? Now, it might seem simple, but that facility has been removed. And now we have the ludicrous system whereby the respiratory clinic will write back to the GP and say, I think this is wrong. Can you refer to my colleague down the corridor? Now, why has that been done? That has been done because the market needs to generate a new fee for a new referral. That's the craziness of the market, right? But what it also does, which is less tangible, it erodes those opportunities to cross-fertilize knowledge and experience. So had that patient been seen by the cardiologist at the say-so of the chest physician, he would have had the professional courtesy to write back and say, yes, your hunch was correct, and this is what I've done. So by doing their job is furthering the knowledge, experience, cohesion, camaraderie, which was taking place naturally. And those natural events have become harder and harder to obtain.
Yeah.
Everybody fighting the bureaucracy, everybody struggling to see the patient and enter reams of data on these very expensive, not clinically designed, but designed by insurance companies, IT systems.
Yeah.
Deeply dissatisfying.
Yeah. And Bob, I mean, and by the way, anybody who's listening, if you want to put a question to Bob, you can either put one in the chat or you put your hand up and you can go on air and put it directly to Bob and have a to and fro with him. But as well, I just remember, Bob, and indeed, I think it's still happening now. There was a move to close more local facilities and to concentrate, on big centres, so-called of excellence. And we were told that, this would deliver a better patient experience. You'd have all that expertise, etc., in one location. But it did mean, unless you happen to be fortunate enough to live close to the concentrated specialist service, as it were, often meant a much further, much longer journey for patients and for people who were, inpatients. A more difficult experience for relatives and friends to travel to meet them. But what's your thoughts on those specialist centres? I mean, is that a good thing? I mean, is there an alternative? I mean, has it improved the the quality of care, or has there been no discernible difference in that sense by bringing those specialisms, as it were, into particular locations?
So this is not a new thing. At the outset, I said that we had district general hospitals, we had tertiary centres.
Yeah.
They existed, but that good idea has been weaponized to justify the closure of your local hospitals.
Yeah.
The vast majority of what most people present with that needs treatment, 95% needs to be done in a district general hospital where you have those community links, where you have a familiar team who can liaise with the GP services. You have those local connections. For that 5%, which is required and did exist, they are using that to whitewash what is a degrading and a contraction of service provision.
Mm. I mean, I think it's pretty clear from what you've been saying, Bob, that, and indeed, I mean, not just from what you're saying, but I think people who've had experience of the NHS, that the quality of care has been diminishing. That's not a criticism of staff, because I think one of almost universal thing that's said by people who do encounter the NHS, that the staff have been overwhelmingly really, really good in that sense. But I wonder if you might just sort of say a word or two about what's happened to staff. And indeed, one of the questions that we've got indeed from last week, actually, that we never had a chance to talk about, just how terms and conditions are being affected by the changes that have been introduced by successive governments over the years.
Yeah, so we know with the junior doctors' strikes that since the 2008 financial crash, their incomes have actually shrunk in real terms by a third. So, that's particularly demotivating, especially with the cost of living going through the roof. So they're struggling to pay rent. They're struggling to make ends meet, pay the bills, and they're working, in very unsuitable, suboptimal circumstances, particularly the acute services. Less so if you're doing the routine work, routine elective planned surgery, for example. So if you're working in A&E or acute medicine or acute surgery, you're there with one hand tied behind your back. There aren't enough support staff or resources or scanners to deal with things in a timely manner. So there's a huge psychological impact in working in those conditions, not far off from a war zone where you having to decide which of the two very sick people you're going to treat, or multiple people with lack of resource, in a system that is actually paying you less year on year in real terms. They're extremely demoralizing. This transfer of control to the managerial parts of the health system has also led to sort of an abuse, a dehumanized approach to staff, whereby, for example, people can't get time off even with adequate notice to go and get married.
Really? Wow.
Or attend funerals.
Good Lord. Yeah.
So on top of this, junior doctors are also paying for expensive exams. So on multiple sides, that they're struggling, they're wondering, why am I doing this? When I trained, for example, I lived on hospital accommodation, rent free,
Yeah.
subsidised food. Now the pay wasn't great, particularly when you were doing hours past the 40 hours. But actually, the sense of respect, the sense of belonging to a greater cause,
Yeah.
it generated goodwill. But there's very little within the NHS now
No,
that generates goodwill.
no, indeed.
You're more likely to feel like an abuse victim
Yes,
working for
indeed.
the NHS.
No, indeed, and it's a tragedy to see that, because I think a lot of people working in the NHS, for whatever level they were at, very much saw it as a vocation, and were really, felt proud, and I guess there is still that sense there, but can see, how they're being devalued. Really, I guess that's a phenomenon really right across the public sector, where, they've been, public sector workers have been devalued. But just say a word or two as well, Bob. I mean, obviously speaking about, from your medical experience, but obviously the ancillary staff play a key role, don't they, in hospitals, and we've had compulsory competitive tendering and best value and all the rest of it. But so how have those sorts of ancillary support service, from the cleaners to porters to the admin staff, etc. What's been going on there, and how's that changed? Oh, just before you come in there, Bob, my partner, she works in admin in the National Health Service in Derby, and she's saying that, believe it or not, I don't know whether this is a common thing across the country, but a lot of the admin stuff in terms of letters, etc., are actually being written, typed up, using the internet in America, and then being sent back over here. I don't know whether that's a common thing, but it seems quite astonishing, really, that you've got people on another continent, all the way over thousands of miles away. I mean, that's a recipe for things to kind of go missing and go wrong or whatever. And she's I mean, she's got certain tales to tell about some of the problems that she's encountered. But just a bit more general thing, though, Bob, in terms of ancillary staff, as I said, right the way across the piece, as I've said, the cleaners, porters, admin workers, etc. How's that been changed over the last sort of 40 odd years or so?
Yeah, so the ancillary staff were the first to be outsourced. So they lost their employment with the NHS, and this was transferred to private companies. Private companies drive down their terms and conditions. You end up getting unsatisfied staff, high turnover. There has been empirical evidence that things like staff hospital-acquired infections went up, particularly MRSA, in hospitals where it was subcontracted early compared to hospitals where NHS still employed the staff directly. If you look at the catering within hospitals, again, vast majority of this, if not all, within England is privatised. The private companies want to maximise profit, so that they end up dishing out cheap, very low nutritional value food for people who need to be eating well to help them recover. So, the cleaning, the food, the hygiene within the hospitals, all of this combined to either make the patients recover well or take longer to recover and be subject to additional risk just by being within hospital.
Mm.
The example you gave of the secretarial work, yes, they're sending scans to be reported abroad. There's no connection with the medical team and the person reporting the scan. Very often, I've heard from colleagues they end up repeating the scan, so you're paying out twice. But also, you're not developing organizational memory. So, I have a secretary. She types up some of my letters, but she's forming networks and connections within the hospital. She knows who to go to for certain things. But if you destroy that job and you outsource one element of it, who's going to do the rest?
Mm.
So the secretaries and administrators are a connection to the patients. They can explain things to the patients. They can explain results to the patients. So
Absolutely, yeah.
they actually save the doctors and nurses a lot of time if you have a good one.
Mm.
And without them, you create additional administrative burden for the doctors and nurses. So what do you want your doctor to do? Spend most of their time making medical decisions or fixing bureaucratic and administrative problems?
I know. Again, just talking a little anecdotally, personal experience. I had a bout of really severe sciatica a couple of years or so ago, and I had to have some hospital treatment. And I'd had a bout of it previously, 4 or 5 years before. And the treatment that I had, it was basically it's like an injection into the spine. I think I spoke to you privately about this, Bob, a while ago. And the second time I had it done, it didn't work. And well, it did eventually, but it didn't work immediately. I mean, my experience previously was that I had this injection in the spine in theatre, and I was fixed immediately. I was no problem, no pain, and I was expecting the same outcome this time, and unfortunately, it wasn't. And it was an admin worker that I spoke to. It was a consultant secretary that spoke. So I was panicking about it, if I'm honest with you. And my partner, who works for a different sort of consultant, but she said, "Well, ring them up," and it was as I say, secretary that I spoke to, and she was able to reassure me. She said, "Look, I'm not a clinician, but I've been working for this particular surgeon for, I don't know, 15 years, I think she said it was. And she said, in my experience, people don't always immediately have instantaneous results. It can take, a few days. Sometimes it can even take a week or two, even a couple of months," she said. Well, that really settled me down, Bob. I mean, I was having a panic attack or something, but I was really, really scared, because I was thinking, bloody hell, I was in such pain still, and I was expecting to be, walking around and no problem, the pain had gone. So I think that's just a really good example of the sorts of experience and knowledge that is built up by the academic sector that does indeed, I think, reassure patients and also save the clinical staff the time and to actually speak directly to patients. I mean, is that something that does that resonate in terms of what my sort of personal experience there?
Absolutely, absolutely. And the managers who make the decisions to outsource letter writing to India or wherever, they're not interested in the impact on the rest of the service.
No.
They're just looking at a spreadsheet. They're looking at a cost saving. They're thinking, I might get a bonus if I save 20, 30,000 pounds making this deal. They're not looking at the additional, not necessarily obvious benefits of having people like secretaries, key administrators, ensuring that things run as smoothly as possible. So there are knock-on effects of decisions made for financial reasons which do not come up in the accountant's thinking on anything.
No, indeed. Yeah. The price of everything, accountants, and the value of nothing. And that old cliche is proof positive, really, I suppose, from the experience in the NHS. But I was also going to ask you, Bob, about people's time in hospital now is, by and large, considerably shorter than it used to be. You'd go in for treatment, and you would tend to spend somewhat more time. But now people are being discharged more quickly. But I mean, you're saying, though, that often it will take longer for people to get well because of the changes that have been brought about. And yet the tendency is to discharge people more quickly than was the case. And again, this is portrayed as as a positive thing, getting people back to their home environment, and they'll recover better there, in familiar surroundings. So I don't know, there may be something in that. But I mean, how do you respond to that, Bobby? Just in terms of the shorter stays now, the faster turnaround, the quicker discharges that we are seeing in the NHS.
Yeah, I have nothing wrong with people being discharged quickly if they're fit and well, and there's a diagnosis being made. Who could argue with that? But what I see more and more is no clear diagnosis, and people sent home because literally there is no space to put them. So somebody's having to take a risk with the patient. I can give you numerous examples. I'll give you one example, which I was thinking about the other day, of a patient in her early 60s who was known to have circulatory trouble. She had clogged up arteries supplying the legs. Yeah. And she had a successful operation. A couple of years later on, she presented to an urgent care centre, which used to be a fully functioning A&E department with medics and surgeons there, but no longer. So she went to the urgent care centre, where she saw, I'm not even sure they were a doctor or who they were, but a junior person saying, look, you've got acute abdominal pain. I don't know what's going on. Can you and your husband make your own way to the hospital down the road? It'll take you half an hour, 40 minutes. Now, the problem with that was a competent, reasonably experienced doctor with a person with a history of poor circulation presenting with severe abdominal pain should be thinking of an aneurysm, right?
Yeah.
This lady proceeded to get her husband to drive her to the next hospital. She arrested in the car. Her aneurysm had popped in the car. An ambulance was called. She ended up going to, I believe it was King's Hospital, might have been Guy's and St Thomas's, where because of the delay in diagnosis, she underwent prolonged emergency surgery. They were unable to close her back up again. She had the aneurysm fixed. She barely survived. She ended up spending almost a year on ITU, intensive care unit, and then she died. Now, I put it to you, had she been to a hospital with a fully functioning surgical and medical team, that maybe this wouldn't have happened.
Yeah.
Certainly, she wouldn't have been asked to drive get her husband to drive to the next hospital.
Mm.
So these are the sort of horrendous, what we call never events that are happening every week up and down the country.
Yeah.
But because they're being normalized now, right? And when families are bereaved, it's very easy to present to the families, well, nobody could have helped this, it's unpredictable. This should have been obvious to a medical student.
Right.
The top differential diagnosis would be an aneurysm, given we know this lady's got knackered blood vessels, right? Until proven otherwise.
Yeah.
But that didn't happen. So yes, she was discharged very quickly from hospital A, but look what happened.
Yeah. Yeah.
And the other problem is the statistics on readmission within 30 days of discharge are deeply flawed. They're bad anyway, but if you got prematurely discharged on a bad decision was made from hospital A, you're hardly going to say, take me back to hospital A, are you?
No, indeed. Yeah. Yeah.
If you've got a choice, you're going to go to hospital B.
Mm.
So they don't show up on the figures.
No, indeed. Yeah. 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 I mean, I guess though there are lots of good outcomes still, aren't there, in the National Health Service? I mean, obviously we're talking about a lot of the problems, but I guess in spite of the political changes, the staff are heroically, still securing really, really good outcomes for people, are they not?
Yeah, no doubt about it, Chris. Most people's experience is favorable, right? If you're waiting for cataract surgery, a joint replacement, you might wait a long time, but when you get dealt with, on the whole, it's a good experience.
Yeah.
Right? The problem arises when you have a life-threatening emergency.
Yeah. Yeah.
All right?
Yeah.
Or if you have something relatively common, which is pregnancy and having a baby, there are scandals up and down the country. There's a new one broke out in Oxford. The John Radcliffe Hospital, I don't know if you saw it last week.
Yes, I think I did.
There are, vast majority of ladies have successful pregnancies and deliveries.
Yeah.
But there's an increasing number of people who either the mother or the child comes to no good. One or other is very damaged or even dies.
Yes.
And this should be something that is a rarity, but unfortunately it's getting more common. Why? Because they've closed maternity hospitals. The morale within the bigger units is very low. Staff have to travel further to get to work, and they're working in an overstretched service.
Yes.
And then when things go wrong, either you blow the whistle and commit professional suicide, or it will get covered up by the managers. That's the reality. If you ask most people how easy it is to get a GP's appointment, I think you're not going to get the answer you might be expecting.
Oh, no.
It's now an uphill struggle, and that's because of how the incentives have been set up.
Yes.
So you could have you could have a GP who's on a very good income who hardly ever sees any patients.
Yeah. Yeah.
How has that been allowed to happen?
And Bob, I don't know if you've got any statistics or you have any thoughts on the fact that the response times for emergencies, the time it takes for ambulances to turn up these days, seems to be considerably longer than it ever used to be. I mean, I don't know if I'm looking back through rose-tinted spectacles, but my sense is when I was a younger man that, if you rang 999 and called for an ambulance, particularly if you lived in an urban environment, they'd be there within minutes. Well, now it can take hours. Even to really serious accidents and medical events. I mean, I was speaking to somebody who'd suspected heart attack, and it was about 5 or 6, 7 hours, I think, before they turned up. Well, I mean, are people dying as a result of these delays in actually getting?
Absolutely. Yeah, absolutely. And, the ambulance staff, if they were able to speak freely without facing some reprimand, they will tell you themselves that there's a fly on the wall documentary every week about the ambulance service. I believe it's up in Hull.
Yeah.
Where the waits are in the hours, not in the minutes. But the predominant problem there is that the ambulance gets you to the hospital, but they can't discharge you to anyone there.
No.
So the patient languishes in the back of the ambulance for hours, waiting to get an assessment in the A&E department.
Mm-hmm. Mm-hmm.
So it's a capacity issue. So it's not like these ambulances are running around from one emergency to the other. They're stuck for hours in the hospital car park.
So the problem then, it sounds then, Bob, from what you're saying, isn't so much that although this may have happened as well, that the ambulance service has been diminished in size. It's the logjam that when they get to the hospital. So it's the impact in the way in which, political decisions have detrimentally affected the ability of hospitals to admit patients. And from what you're saying, that sounds to be the problem. It's not so much the ambulance service end, although there may be issues there as well. Perhaps I don't know. But it's more this when they get there, and indeed, I mean, again, it's only kind of straws in the wind and anecdotal evidence. I mean, a friend of mine was involved in a very serious, in fact, fatal accident, and it was hours before anybody turned up to him. And he said, and he was, I mean, he was whiplash injury, so he was in a lot of pain, but no broken bones or anything like that. But he said, so it was a long time before they actually arrived at the scene. And when they did arrive and take it to the hospital, he was then waiting in the ambulance. I think he said for about 2 or 3 hours. So that ambulance was then tied up, unable to go anywhere else. So, I mean, if this is being replicated all over the country, this is a massive problem, isn't it?
It's huge. So you've got the inability of ambulance staff to be able to hand over their patient. That's one problem.
Yeah.
But don't forget, there's a greater distance between A&E units now because so many have shut down.
Yeah,
right?
yes.
So ambulances are spending longer and longer on the road.
On the road, yeah.
And then that has the knock-on effect. I'll give you one example of a patient in my surgery. So this was a chap in his mid-30s. Unfortunately, he developed a cancer. He was doing well on chemotherapy. He was having chemotherapy, but he attended my surgery with a raging fever, sweating buckets, looking very ill, right? Now, somebody who's had chemotherapy with that sort of clinical picture, you have to suspect something called neutropenic sepsis.
Right.
His immune system had been totally clobbered by the chemotherapy, and he is now at death's door. Every minute could mean he could go into septic shock. He languished on my couch in one of the consulting rooms for 2 hours, and I'm literally 10 minutes from the ambulance station.
Wow.
He could have died in my surgery.
Yeah.
Thankfully, he didn't die in the surgery.
Yeah.
But, there comes a point where, particularly people at the sharp end, you can only take this for so long, right? And if you're like me approaching 60, you're going to say, I don't want to do this anymore.
No.
I'm going to go, right? You're going to look for the exit. and you end up losing all the people with the experience, and particularly the organizational memory of how things could be and used to be at much less cost.
Yeah.
We mustn't forget this. I'm not speculating that we need a huge investment. We've talked time and time again
Yes.
about the misallocation of resource and the problems caused by fragmentation and delay and staff dissatisfaction and all these other problems. So, I'm lucky I run a reasonably tight ship. My patients are generally quite happy. They've got good access. But when I speak to other colleagues, they tell me, that people struggle to get an appointment. They spend the first half of the appointment complaining about how long it took to get an appointment.
Yeah.
So,
Yeah.
if you hear that time and time again, you think, I've had enough.
No, indeed.
I'll get a back office job and not have to put up with the
Sure.
growing dissatisfaction, legitimate dissatisfaction.
Yeah.
But it's the healthcare workers that bear the brunt of that dissatisfaction.
No, indeed. As we kind of come towards the conclusion of our conversation today, and again, if anybody's got any comments they want to raise, please feel free to ask away. I mean, Bob, you've been diagnosing the problem very eloquently. What's the cure? How do we get out of this? And what can people do to bring about the change that's desperately needed to recreate the National Health Service that I think we know and love, and unless you've actually had experience with the NHS, a lot of people probably still think it's in rude health in the rude health that it previously was when they maybe last had an encounter with it 30, 40 years ago. Because sometimes people are fortunate enough to not have to, if they've been been unlucky enough to be be healthy and not require the services of the NHS. I mean, people will often think that things are honky dory. It's only when they actually need an ambulance or need to get treatment or need a GP appointment, whatever, that they start to find that things aren't quite as they thought it was. So, what's the cure, Bob? I mean, we've sort of diagnosed what the problem is. How do we get over it?
I think the headline has to be renationalisation. We need to bring some accountability within the NHS. At the moment, the senior managers who make all the decisions within a hospital, there is no accountability. When did you last hear anybody getting convicted for corporate manslaughter? But that's what's going on in a lot of trusts up and down the country. So we have a accountability deficit. We also have a truth deficit because whistleblowers are routinely scapegoated and professionally crucified. So it takes a very strong and determined person to risk their career to even raise the alarm about what's going on. And because they can't speak freely, people don't have the correct perception about what the problems are. We keep being spun by the media. Oh, we can't afford it. We need more money. That isn't the problem. You know what I mean? If the public have the perception that this can never be fixed, we can't afford it, then naturally they won't ask for that as a solution.
Yeah.
Or they won't ask for the right solution. And the right solution is stop the misallocation of resource, introduce accountability, protect whistleblowers, give them very, very strong employment rights. In fact, promote whistleblowers and make them in charge of patient safety, because this is the character of the person I want in charge of protecting my safety.
Yeah.
Not somebody who will brush everything under the carpet for their own career and financial advancement. That's what happens at the moment.
Yeah.
And you just need to fix the culture. If we also get on top of the causes of chronic disease, which is unfortunately a lot of lifestyle stuff. We're eating the wrong food. There's a obesity epidemic in the whole Western hemisphere because we're eating processed foods, we're eating junk food, we're eating too much of it. We're hooked on sugar. Well, that's a quite obvious and simple public health issue to fix.
Yeah.
But there isn't a political will because there's too much money to be made making us sick.
Mm.
And the other thing we need to consider is, in terms of pharmaceuticals, well, we need a national generics pharmaceutical company which is going to give us products that aren't designed for profit. And in terms of any new treatments that come out, they need to be independently assessed. Are they better than what we're currently doing? Or are they just a huge kickback for pharmaceutical companies?
Yeah.
Because a lot of money is being wasted in very profitable interventions which have minimal benefit to the patient.
And should we be demanding as a public, or what you've just said as well, but the re-establishment of community hospitals that's been closed down, or is that just pie in the sky and not worth pursuing, do you think?
I think there's a place for intensive rehabilitation units outside of the acute hospital. And if you fix the things that we've talked about, it will liberate resource to do this. Getting a physiotherapist to go around to 4 or 5 people and giving them physiotherapy at home is a huge waste of time for that physiotherapist. Is more than half the time he's spending traveling.
Yeah.
It makes a lot more sense to have the patient and this expertise in one place.
Yeah.
Not to scatter them to the winds, which is what's happening now. So, yes, we need to re-establish some of the things that worked in the past.
Yeah. I remember, again, it's like a trip down memory lane. I keep sort of thinking, I'm getting old now, so I remember some of this stuff. But I remember, people when they were initially discharged, but they wouldn't necessarily always be discharged home. They'd be discharged to a convalescent place. I don't know if you're familiar with, is there a place for that? I guess in terms of what you just said, there's some sort of convalescing centres, would be more efficient to sort of do the sort of, the treatment, follow-up sort of rehabilitation treatment that you just sort of set out, rather than, spending half the time travelling on the road from home to home, as it were.
Yeah, there's definitely a place for that. There are still some of those services. We have a very limited sort of rehabilitation, half a dozen beds. So that sort of provision can be expanded.
Yeah.
As long as the people being discharged there are appropriate, then we're onto a winner.
Sure. Yeah.
Compare that to being dumped at home. So we had a patient only last week or the week before who was sent home prematurely. I think they'd already had a fall, came home and broke their hip.
Oh, yeah.
Because the support services were not provided.
No.
And that patient clearly wasn't safe to go home.
Yeah. I guess there's also, isn't there, as well as the rehabilitation centres, convalescent centres, whatever you want to call them, a need for a root and branch reform of an improvement of the sort of social care system in this country, because that's been used as a cash cow for the private sector by and large, and it's not really fit for purpose. And the sort of horror stories that you're talking about, I think, just point that up, really. If there'd been a better social care system in place, and some of the difficulties that you've outlined, could have potentially been avoided with that more intense level of home support, as it were. But it's being done on the cheap, and not only that, it's being done in a way where the first call on any investments is to drive profits and dividends to shareholders. It seems a crazy way of running the thing, doesn't it?
I disagree with you on being done on the cheap.
Well, what I meant, Bob, sorry, I know what you're going to say, but please do say it. When I meant just in terms of the terms and conditions for the staff, social care workers are some of the lowest paid people. But I take your point, but go on and expand that point that you were just about to make.
So if you look at how much money is going into the care of people in nursing homes or other long-term institutions, a fraction of that goes to the workforce. The environment within the patients kept is stark. Most of the money is floating out the back door.
Yeah.
So again, it's misallocation of funding. And And more, because it's all means tested, this is a way of ensuring that there isn't any intergenerational wealth transfer in the working class.
No, indeed, yeah.
Because age now becomes a financial burden.
Yeah, sure, yeah.
Right? So you cannot pass on your house to your family because it's going to pay for your care.
Yeah.
And it's going to private equity.
Yeah. No, indeed. I mean, the whole thing's a scandal, really. And I mean, you know, like you have the residential care homes, the kind of the nursing homes, and how money's being, like you say, siphoned off, and the staff are, you know, not paid well. And then, of course, you have the, you know, the domiciliary care people, you know, helps, sort of a better way of putting it, you know, going out. I mean, and they're by and large almost exclusively in the private sector now, and you know, poorly paid, and you know, the motivation, of course, you know, diminishes somewhat. You know, if you're being devalued like that, and just in terms of the people that you're recruiting.
I've seen for myself when I visit people at home, the care and compassion of the people delivering those services to people in their own homes.
Yes.
And when you find out how little they're being paid, how they're not paid for transport, getting from one place to the other, how some of them have to use public transport to get from one house to the next, it's utterly shocking. So if you work out their take-home pay, you're lucky to get above £5 an hour.
No, indeed. No, it is a shame.
And this is the, you know, if we value humanity, if we value care, if we value our loved ones being looked after well, the carers should be rewarded quite handsomely, not being scraping by.
Very much so.
Because that's not an easy job. It's not an easy job.
They're doing some of the most important work that you could ask anybody to do, because they're looking after our parents and grandparents. And so you really want people, don't you, that's, you know, really at the top of the game in that sense, and should be properly remunerated, you know, for doing that really important work. Listen, Bob, we've been going for about an hour, so we'll kind of wrap it at that. But I mean, I think we've touched on some really important issues tonight, and thank you for that. And indeed, touched on some really interesting topics that I think we should revisit. For example, your point about you know, public health and diet and stuff like that, and you know, the role of the food industry in you know, the poor health that a lot of people are experiencing now, the obesity crisis and so on. And so maybe that's something that we should return to in another episode of Call the Doctor. But thank you, Bob, again for tonight's input. We'll be back next week on Sunday at 5 o'clock, and I hope you can join us again then. So thanks for tuning in, and thanks again to Bob.